Good morning. My name is Dr. Gabriela Milla-Godoy. I am a resident physician, internal medicine at Metro West Medical Center, Framingham, Massachusetts, and it is my pleasure to present to you this case of fulminant COVID-19 associated myocarditis in an otherwise healthy female. As an introduction, we are all very familiarized that COVID-19 has become a global pandemic. By this graph by the WHO, it is seen that the Americas have been the ones most affected in morbidity and mortality. This case, it's about a COVID-19 associated myocarditis in a 45-year-old female. She presented with only gastrointestinal symptoms and she deteriorated rapidly. This case, in general, highlights an atypical presentation of COVID-19 with a fulminant course in this emerging and evolving disease. To start our case, the patient was a 45-year-old African female. She was a nursing assistant and she presented to the ED with 4 days of diarrhea, nausea, and vomiting. The patient had close contact with COVID-19 positive patients at work. She denied any respiratory symptoms, chest pain, or fever. She was a non-smoker. She was on no medications. Her vital signs in general where the patient was hemodynamically stable with tachycardia with a heart rate of 116. Her examination was unremarkable except for an overweight diaphoretic female in distress with abdominal tenderness and cold and clammy extremities. Her lab work findings were significant for a WBC of 3.8, platelets of 144, lactic acid of 2.97. The patient as well had AST of 141, CK of 693, proBNP of 4,585, and the most highlighting finding was that she had a troponin T of 0.43. Her chest x-ray, as it is shown here, showed patchy infiltrates bilaterally. Her COVID swab was positive, PCR, and her EKG showed sinus tachycardia and diffuse ST segment elevations in what was 1, 2, AVL, and from B3 all the way to B6. The patient initially received 2 liters of normal saline, hydroxychloroquine, aspirin, and atorvastatin for presumptive COVID-19 myocarditis. She improved, symptomatically remained stable, was admitted to the floors. However, 2 hours later, she became lethargic with a heart rate of 130. Blood pressures and pulses were unmeasurable. She received another liter bolus of normal saline, and she was transferred immediately to the ICU. Bedside echocardiogram showed that she had an ejection fraction of 10% with global hypokinesis and no pericardial effusion. Posteriorly, the patient developed cardiogenic shock. She was intubated, started an IV dopamine, epinephrine, and phenylephrine, IVIG, and methylprednisolone. However, subsequently, she became asystolic. She received 4 doses of IV epinephrine, 1 amp of bicarb, and unfortunately, she expired after 15 minutes of resuscitation. Our discussion: COVID has caused significant morbidity and mortality worldwide. We know that the main target is the lung. However, there have been recent reports of cardiovascular complications, including fulminant myocarditis, where there is no established guidelines. This case, it highlights the importance of close monitoring in patients with elevated cardiac biomarkers, as it is concerning for an independent marker of mortality in patients with COVID-19. Thank you very much.